Hi everyone, my name is Katie Lee Hornberger and I am a certified genetic counselor with 10 years of experience in assisted reproductive technology and preconception genetic counseling. And today you are tuned in to a 1-hour lecture on assisted reproductive technology and pre-implantation genetic testing. So stay tuned for the outline. So the main things I'll be covering today are what is ART, what are the different types of assisted reproductive technology, or the main different types, and what is PGT, pre-implantation genetic testing. So let's get into it. One fun trivia question before we get into the meat of the talk: who knows what the largest cell in the body is? It is the human egg cell, or the ovum. Let's talk a little bit about the anatomy of the human egg cell and the human sperm cell. So there's essentially two layers around the egg cell. These are follicular cells, and this is the zona pellucida. It's kind of called a jelly coat. It's the barrier of sperm to enter. The follicular cells, they are the cells that provide nourishment to the egg cell. Within the egg cell, the main thing to be aware of is the nucleus here. And then, of course, there's cytoplasm in the middle. When we think about the sperm cell, it can be divided into three sections: the head, the midpiece, and the tail. The head is going to contain the nucleus, this large, what's pictured in purple here, the acrosome cap, which includes enzymes that are going to help the sperm penetrate the egg, and then the centriole. The midpiece contains mitochondria that help give the tail the energy it needs to move. And then the tail, it's also called the flagellum, is essentially a microtubule structure that helps the sperm move. Next, let's talk about embryo development and embryo anatomy just briefly. Here you can see a picture of the different stages of development of an embryo from day one, which is called the 2PN or 2 pronuclei stage, where you can see these the nuclei from the egg and the sperm starting to fuse together, starting to come together. All the way through to blastocyst stage, which is typically reached or achieved on day 5 or day 6. At blastocyst stage, what we're looking for, or what embryologists are looking for, are two different types of tissue that are forming. The trophoblast, also called the trophectoderm, these cells that have been pushed a bit towards the perimeter that would form the placenta if the embryo results in a pregnancy, and this clump of cells here, which is called the inner cell mass, or the embryoblast. Those are the cells that would make up the embryo or the fetus if this embryo resulted in a pregnancy. Let's talk a bit about the different types of assisted reproductive technology, and we'll get into each of them in a little bit more detail. Essentially, ART, or ART, is defined as any type of treatment which includes the handling of eggs, sperm, or embryos. So that would include intracervical injection, intrauterine injection, and in vitro fertilization. And ART can be used by all sorts of different people. It's not just used by people with infertility. It can also be used by couples who do not have both a sperm-producing and an egg-producing partner, people who have banked gametes in the past and they now need to use them even though they may not have fertility issues. It can be used by people who can't carry a pregnancy, so they need to use a gestational carrier. And it, of course, can be used by single parents by choice. So there are many reasons that people might come to us to utilize ART. It's not just because they have infertility. Let's first talk about intracervical insemination, or called ICI. Here on the left, you can see this visual of ICI, where sperm is injected as close to the cervix as possible using a syringe without a needle. And then here, in contrast, is intrauterine injection, where you can see, or intrauterine insemination, where you can see that the sperm is put all the way into the uterus. The thing about ICI, which is often referred to as at-home insemination, is it can be performed by the patient themselves or their partner at home. So you don't need to go into a clinic to do this. Many patients who don't have reduced fertility or infertility might try this before they move on to treatment in a clinic, mostly because it's less expensive, less invasive, and more comfortable for a lot of people than an IUI cycle. The patient needs to track their ovulation so that the intracervical insemination can be done at the correct time to give them the best chances of success. I'm inserting a quick video from Fairfax Cryobank, which is a sperm bank, just to show you what it's like to receive an ICI vial at home. You'll see in this video, the person has just received the box, a shipping box, and inside of that shipping box is a small cryo tank, and they'll take it from here.
So I'm ready to thaw. I'm gonna pull the cane out. Now this aluminum cane is very cold, and that's why it's good that I have these gloves on. And then I have my vial here. It's an ICI vial. And I'm gonna pull it off the cane, and I'm just gonna place that cane right back into the tank. And then I'm gonna place this right on my side table, and I'm gonna view it. And it says, I'm gonna compare it to my packing slip. Donor 2854, specimen date 11509, vial number 2, GIVFP, everything matches. Once the vial is thawed, you're gonna pick it up. At this point, it'll be room temperature, it'll be warmer. And when you turn it up and down like this, you're gonna see that there's about a half a mil, there should be a half a mil of sample in here, which is a very small amount, but there are 10 million total motile cells, at least 10 million total motile cells in this little vial, and that's all you need for an insemination. But once the sample's in there, what you'll do is you're just going to, either you or your partner will insert it into the vagina, deposit the sample, and I don't push hard. I would just push slowly to deposit the sample right onto the cervix, and then you're good to go.
Let's talk about intrauterine insemination, or IUI, going up the totem pole in level of invasiveness. This is usually performed at an OBGYN office or at a fertility clinic. With IUI, the timing does have to be precise to improve the chances for success, just like it must be for ICI. So the IUI procedure should occur just one day after the LH surge. By using IUI, it increases the number of sperm that should reach the fallopian tube. And a reason people might choose this over IVF is it is much less invasive and much less costly than IVF. It's commonly used in individuals who have unexplained infertility or have malfactor due to decreased motility or decreased count. Of course, it's also used by individuals who do not have a sperm-producing partner as well. Success rates, I would say on average, I hear most clinicians quote maybe a 10 to 15% chance that each IUI cycle will result in a healthy ongoing pregnancy. So it is not a super successful method of conception. IVF generally will have a much higher chance of success. Again, this depends on specific factors. A lot of people are surprised to hear that the success rate for IUI is so low, and that's because a lot of things need to happen for an IUI to go right. For those of you who are visual learners, I'm going to pass it off to Dr. Randy Morris from Naperville Fertility Center to explain a little bit more about IUIs and how they work. I don't have an affiliation with any of the providers or clinics that I'm showing videos from. I just think they're nice explanations to break up the talking in my presentation. So here we go.
First, some basics. When a couple has intercourse, some of the sperm gets stuck in the mucus and glands of the cervical canal. Some of those sperm never make it out, but some can be released very slowly over the course of several days. This is why it is possible for a couple to become pregnant even if they have intercourse up to 5 days before ovulation. An IUI is an intrauterine insemination. This means that the sperm are placed directly into the uterus, bypassing the cervix completely. This results in two things being different. First, more sperm are able to reach the fallopian tubes where fertilization occurs. Most studies show higher pregnancy rates when IUI is used compared to intercourse. Second, because the cervix is being bypassed, the sperm doesn't stay around for as long. As a result, it is more important to get the sperm into the uterus closer to the time of ovulation. Determining the time of ovulation is therefore very important. Ovulation occurs in human beings because of a hormone called LH, or luteinizing hormone. LH comes from the pituitary gland. Before ovulation, the amount of LH being produced by the pituitary increases by a huge amount. This is known as the LH surge. As a result, LH levels in the blood get higher, and this can be measured with a blood test. When the blood eventually goes through the kidneys, the LH is filtered into the urine, so LH can also be measured in the urine. This is the basis for every home urine ovulation test.
Next, let's talk about IVF, or in vitro fertilization. It's important to know that this is much more costly and much more time-consuming than an IUI cycle. There are many different appointments that will be required with the reproductive endocrinologist or at the IVF clinic to prepare a patient for IVF. The steps that are required are going to begin with ovarian stimulation. So injectable medications are going to be used to increase the number of eggs that can be retrieved and to improve outcomes for success for a good number of embryos. Now, there is the possibility of doing a natural cycle without using all of those injectable fertility medications, but that typically results in 1 or maybe 2 eggs. So a much lower outcome. It's not typical for most patients to utilize a natural cycle. After stimulation and a trigger, it will be time for the egg retrieval. The egg retrieval is performed by the reproductive endocrinologist using an ultrasound-guided needle to collect each of those eggs out of the ovary. Once the eggs are cleaned up, or the cumulus cells are cleaned up off of the egg, fertilization occurs. And there are 2 main ways to fertilize eggs that are created or retrieved, I should say, with an IVF cycle. One is conventional fertilization, and with conventional fertilization, or also called conventional insemination, sperm and egg are just mixed together. Sperm are added to the egg, and many sperm have the opportunity to attempt to fertilize each egg. What's more standard these days is ICSI, or intracytoplasmic sperm injection. With ICSI, just 1 single sperm cell is injected into each egg cell. That is the preferred method, especially for any patients who are planning to utilize preimplantation genetic testing on their embryos. The next step is going to be the embryo transfer, or perhaps embryo freezing, depending on what the plan is for those embryos. Once the embryos are cultured in the lab, oftentimes they might be biopsied at blastocyst stage so that PGT-A, or a different form of preimplantation genetic testing, can be performed. If they're biopsied for any testing, then the embryos are typically frozen, and the embryos will be frozen and stored at the clinic, while the biopsy from each of the embryos is sent off to a laboratory for testing. Once the results get back, if there are any chromosomally normal or PGT-M normal embryos to transfer, the embryos are thawed and transferred. If a patient is not doing any genetic testing, or even if they are, they likely, even if they're transferring 1 embryo fresh straight into the uterus after it's cultured, they can still freeze the remaining of their embryos to use for family building in the future. The cost of an IVF cycle and a transfer is usually around $20,000 to $40,000 per cycle, so it is very costly. Many patients are not able to create an embryo on their first IVF cycle, or a chromosomally normal embryo on their first IVF cycle. So patients might get anywhere from 0 blastocysts or 0 embryos ready for transfer to 10 plus. 10 plus is incredibly rare. It is not uncommon to get 0, 1, or 2 embryos out of this whole costly IVF cycle. Depending on what literature you look at, and depending on the specific characteristics of a patient, the chance for a baby from a single IVF cycle and transfer ranges from about 1 to 43% per cycle. The best case scenario, that 43%, those are our youngest patients. So usually patients where the person providing the egg is under the age of 30. I'm going to show a TED Ed video that is a visual representation of IVF and how it works. It's created by Dr. Nassim Asefi and Dr. Brian Levine. It's a great video, and I highly recommend finding it on YouTube and watching the rest. And if you haven't already checked out TED Ed videos, they're so fun. I love watching them with my son. So here's this.
In 1978, Louise Brown became the world's first baby to be born by in vitro fertilization, or IVF. Her birth revolutionized the field of reproductive medicine. Given that approximately 1 in 8 heterosexual couples has difficulty conceiving, and that homosexual couples and single parents often need clinical help to make a baby, the demand for IVF has been growing. IVF is so common that more than 5 million babies have been born through this technology. Now, how do you make a baby in a lab? In patients undergoing IVF, FSH is administered at levels that are higher than naturally occurring to cause a controlled overstimulation of the ovaries so that they ultimately produce multiple eggs. The eggs are then retrieved just before ovulation would occur, while the woman is under anesthesia through an aspirating needle that is guided by ultrasound. Most sperm samples are produced by masturbation. In the laboratory, the identified eggs are stripped of surrounding cells and prepared for fertilization in a petri dish. Fertilization can occur by one of 2 techniques. In the first, the eggs are incubated with thousands of sperm, and fertilization occurs naturally over a few hours. The second technique maximizes certainty of fertilization by using a needle to place a single sperm inside the egg. This is particularly useful when there is a problem with the quality of the sperm. After fertilization, embryos can be further screened for genetic suitability, frozen for later attempted pregnancies, or delivered into the woman's uterus via catheter. Common convention is to transfer the embryo 3 days after fertilization, when the embryo has 8 cells, or on day 5, when the embryo is called a blastocyst and has hundreds of cells.
When I got my first job out of grad school, I was working at Colorado Center for Reproductive Medicine, an IVF clinic. And when I first started, I had the ability to shadow the embryologist. It was simply fascinating to me to see the process and to actually see the eggs and sperm and embryos under the microscope. So I want to show that here. I found this video on YouTube, and what you can see is one of the embryologists is putting the cleaned up eggs, the eggs with the cumulus cells removed, into a new petri dish. They're getting ready to perform ICSI, which is the standard method of fertilization at most clinics these days. After a few different tests to select the best sperm, the most motile, best looking sperm, once selected, and there you go, it's pushed right into the egg. On the left, you can see it's being held onto, the egg is being held onto with a pipette with a little bit of suction, and there goes the sperm into the center. The embryos are kept in the incubator for a day or so, and the next day they check to see if fertilization occurred. They're looking for this 2PN or 2-pronuclei stage, where you can see the nucleus of the sperm meeting the nucleus of the egg. Then they continue to be cultured. Day 3, they usually should have 8 cells, moving on to morula after day 3. And then hopefully by day 5 or day 6, you have a blastocyst where you can see the trophectoderm and the inner cell mass clearly. The embryos are graded at this stage based on how they look, the morphology of the inner cell mass and the trophectoderm. Okay, and then here we have a transfer. That is one little blastocyst embryo being loaded into a catheter right here. And here we go. The reproductive endocrinologist is getting it ready for a transfer. This might seem like a relatively easy procedure compared to the retrieval and other parts of IVF, but it is actually essential to the success, the pregnancy rate, and the live birth rate that this embryo is placed in the perfect position in the uterus. So here we go. You can see the catheter with the embryo being pushed into the uterus. One thing I do want to point out, because those videos I showed really simplified things, is that the process for a patient undergoing an egg retrieval, an IVF cycle, an embryo transfer is not easy. There are a lot of medications that can have some really impactful side effects, and there are also a lot of visits to do monitoring ultrasounds and blood work, either to their IVF clinic or a clinic that is going to follow them until they fly or drive a long distance to go see their IVF clinic. So it can be really challenging to work, to take care of other kids or your family, and complete your normal requirements that you need to do each day when you're undergoing an IVF cycle and an embryo transfer. Not just physically, mentally, emotionally, but also because it takes a lot of time. Because it's not as straightforward as one might expect, I just wanted to put up some calendars as an example that demonstrate what an egg retrieval cycle might look like and what a transfer cycle might look like, and all of the medications and all that's involved to prepare for each. I'm not going to go into details because it is never a genetic counselor's job to monitor someone on their cycles, but I just want you to know that it is a quite involved process. Now that we've covered the basics of assisted reproductive technology, so we've talked a little bit about ICI, IUI, and IVF, let's talk about what options are on the table if an individual or a couple has an increased chance to have a child with a genetic condition. One of the first options an individual could consider is just spontaneously or naturally conceiving, if that's an option, and then utilizing prenatal diagnosis, so testing during pregnancy or screening during pregnancy to see if the pregnancy is impacted. And there are obviously all different types of prenatal screens and tests, each with their own accuracy and kind of pros and cons that could be utilized. But certainly some individuals might go that route, and some individuals may seek a prenatal diagnosis as they may want to terminate a pregnancy if the pregnancy is impacted with the genetic condition, or they may just want to prepare their family and their friends and maybe consider speaking with specialists throughout the pregnancy and being better prepared for when the baby arrives. Option number 2 would be to conceive spontaneously or naturally, if that's an option, and utilize postnatal testing. So not everyone wants to do or can do testing during pregnancy due to multiple reasons. And for that reason, postnatal testing is sometimes a good option for different families. If this is a condition where treatment is readily available and they find out that their pregnancy or that the baby is impacted shortly after delivery, then they could certainly pursue treatment. Option 3 is to avoid pregnancy, and sometimes avoiding pregnancy looks like remaining child-free or childless, or with the same size family that was already built, or that might look like pursuing different options like adoption. And then lastly, option 4 is where we'll probably spend the bulk of our time in discussion today. A couple or an individual could significantly reduce the chance for a condition in their child by utilizing assisted reproductive technology. And that could look like using donor egg or donor sperm or donor embryo to reduce the chance for that specific genetic condition, depending on the inheritance. Or it could look like utilizing preimplantation genetic testing for a monogenic disease to reduce the chance for that condition. As we discuss the different options, I will show some example reports and this pedigree. This is a completely made up family, but I do want you to know that it is very similar to many families I have seen while working in the IVF clinic and working at the PGT laboratory as well. Let's pretend we are ART genetic counselors. We work at an IVF clinic and a couple presents to us. They show up on our schedule for an appointment. We learn that their names are Tyrese and Meredith Chen. They are 39 and 40 years old, and they are both carriers of spinal muscular atrophy. You take a family history from the couple and you learn that they had a daughter named Molly who passed away from spinal muscular atrophy. She was the first person diagnosed with spinal muscular atrophy in the family. And it was after her diagnosis at 7 months that Tyrese and Meredith had testing and found out that they were carriers of SMA. Unfortunately, Molly passed away when she was 7. Since then, the couple had a son named Jarrett. They did testing on him with amniocentesis, and they found out that he was a carrier of SMA. He's doing well at 4 years old. They had another pregnancy. That pregnancy was in 2018, and unfortunately, that baby was found to be affected with SMA. The couple decided to terminate that pregnancy at 18 weeks after getting the amniocentesis results that confirmed that Junior was affected. They are still hoping to grow their family, so they have had another pregnancy in 2021. That pregnancy unfortunately resulted in a 9-week miscarriage or spontaneous abortion, which I abbreviate as SAB. The couple shares with you that after a few months after their miscarriage in May of 2021, they started trying to conceive again and that they have not been able to fall pregnant again. And it's been almost a year of trying, or I should say 9 months or so of trying. They desperately want to have another child to add to their family, and they also want to reduce the risk to have a child with SMA. They tell you that they can't go through that again, and the reason that they're seeking fertility treatment is, one, to reduce the risk of SMA, but also because they have been trying to conceive and they've never struggled for 9+ months to get pregnant, and Meredith suspects it's because of her age. So they're interested in utilizing assisted reproductive technology to improve the chances of conceiving and also to reduce the risk of SMA. And they want to know what their options are and what it will look like. While you're speaking with them, they provide you with their genetic testing results. You can see Tyrese's here on the left. He's a carrier of 3 conditions: GJB2-related non-syndromic hearing loss, spinal muscular atrophy, got 1 copy of the SMN1 gene, and alpha thalassemia. He's a silent carrier. And then Meredith here, she is a carrier of just 1 condition out of the 175 she was tested for. She's a carrier of spinal muscular atrophy. After taking the family history and reviewing the carrier screening results, you're ready to discuss different options with the couple. Now, if Meredith and Tyrese were my patients, I may not go into all of the detail that I'm about to go into about each of their different options to reduce their risk of having a child affected similarly to their first daughter, Molly. But for the sake of this example, we're going to dive into each of them. The first example is to conceive, whether it be naturally or utilizing ART, and utilize prenatal diagnosis or prenatal screening to determine whether the pregnancy, the fetus, is at an increased risk to be affected, and then to make medical management decisions based upon that information, perhaps to consider terminating the pregnancy or to seek options such as seeing specialists, planning to deliver at a hospital that's more equipped to handle a baby if necessary. Classically, the two options for prenatal diagnosis are CVS chorionic villus sampling and amniocentesis. These are both invasive tests where a needle is inserted into the pregnant person's abdomen, typically with CVS. Sometimes it can be done transcervically. And a sample of tissue is collected, and that tissue is tested for the specific pathogenic mutations or the specific disease of interest. CVS is available earlier at 11 to 13 weeks gestation, where amniocentesis typically becomes available at about 15 weeks gestation and beyond. CVS is, of course, testing a sample of the chorionic villi, where amniocentesis is getting a sample of amniotic fluid, which contains skin cells from the fetus. Both have a very good accuracy of greater than 99%. However, CVS can have some limitations when it comes to testing for chromosome imbalances, just because the placental tissue can differ from the fetal tissue. Now, the other option that I've included here is NIPT, or non-invasive prenatal testing. The use of NIPT has increased drastically the last 5 years. And most recently, a couple of laboratories, or I should say more than a couple of laboratories, have come out with NIPT for single gene diseases. SMA is one of the conditions that NIPT can test for. The benefits of NIPT would be that it is available, that it can be done at usually just 10 weeks of pregnancy, 10 weeks gestation, giving a patient information earlier, and that it does not require an invasive procedure. It is just a blood draw. That being said, accuracy is definitely going to vary, and with NIPT for chromosome imbalances, providers know that that should be treated as a screening tool and should always be confirmed with prenatal diagnostic testing. Medical management decisions such as having a termination or an abortion of an affected pregnancy should never be made based on NIPT for chromosome imbalances. Now, this is an area that's really rapidly evolving for single gene diseases, and I would just want patients to know whether or not it's available for the specific condition that they're concerned about. Now, we know Meredith and Tyrese are already familiar with amniocentesis, as they've had that procedure done on 2 previous pregnancies, so I wouldn't go into it in detail with them. But for all of you future genetic counselors, it's important to stay on top of literature regarding NIPT if you are going to be doing this type of counseling, and if it's available for a specific single gene disease or not. And then to know the ins and outs of how to explain CVS and amniocentesis. It will also be important to know any state laws in the areas that you practice and whether that is going to limit the possibility that a patient have a termination if she desires one after having her amnio or CVS. Okay, option 2, conceive, whether that be naturally or utilizing ART, and use postnatal testing and treatment if the baby is affected and treatment is available. Now for SMA, I believe about 7 years ago, treatment called Spinraza became available that can significantly improve outcomes of individuals who are affected with SMA. So it is very important to at least have an idea of what conditions might have treatments available or on the horizon, or any exciting clinical trials. And while I know I cannot be an expert in every single gene disease I counsel on or see a patient who has that in their family, it is really important that I know where to refer patients who might want to learn more about this, and that I can get them the right contacts to learn more about treatment for the disease of interest in their family. So, of course, every single patient has the right to decline any testing in pregnancy, such as NIPT, CVS, or amniocentesis. That is always a choice that a patient can make. What they could choose to do instead is to have their baby tested when they're born to determine whether they're affected or unaffected. Or, depending on the condition, whether it's childhood onset, teen year onset, adult onset, the testing could be delayed into later in childhood or adulthood, or depending on what that patient themselves, the child of the patient desires, it could be deferred completely. Now, if an individual is tested and they are found to be affected with the condition and treatment or clinical trials are available, the family should be informed. If a couple like Tyrese and Meredith presented to me, and I see that their daughter Molly was born in 2007, before treatment for SMA was much more widely available, I would want to make sure that they're aware that there is now a treatment and that it makes a significant difference in how affected children do. They may not be aware, depending on whether they're involved in the SMA community or not, So that would be something I would mention. And if they were curious about it and wanted to learn more, I would refer them to a genetic counselor, a geneticist, or a physician who specializes in SMA in children and who treats them, so that the couple could get more information about what treatment looks like and how it impacts quality of life and life expectancy and so forth. As carrier screening continues to expand to include milder and milder conditions, things like non-syndromic hearing loss, non-classic congenital adrenal hyperplasia, I think it is very important to be aware of this option that was not in your textbook, to conceive and utilize postnatal testing and consider treatment if necessary and available, because not everyone is going to fall into those other three options. There are many people who will be comfortable, depending on the condition and their worldview, conceiving a child with some of these diseases. The next possibility is to avoid pregnancy. So a couple or a patient may decide to remain child-free or childless, or if they already have a child or children, to stop building or adding to their family despite their desire to, or they may consider adding to their family through adoption. You might think there's not much to add regarding this option, that it's pretty straightforward, just don't conceive, either remain child-free, stop building your family, or adopt. But there is, and this is not something that I ever learned about in grad school, because I personally have been interested in foster care and adoption since I was a child. I have done a lot of research on it in my own time and through getting foster care certification with my partner. I think it is really important that us genetic counselors have a little bit of an idea about some of the issues surrounding adoption and foster care, so we can be more sensitive about the way we discuss it and just be aware of what the lived experience is like for people who've gone through adoption or foster care. It's common for people to offer advice to individuals who have infertility and say things like, well, why don't you just adopt? Why don't you try foster care? That's a cheaper version of adoption. And the huge problem with that is that adoption and foster care, they are about the child. It's about finding a family, a loving family or home to take care of a child. It's not about finding a baby for a family or finding a child for a family. And people who've gone through infertility or difficult experiences around conception or losing children to single gene diseases have trauma around that. And their trauma needs to be healed before they can help a child who is almost certain to experience some level of trauma due to being raised by a different family. There are many amazing voices of adoption and foster care through social media. So what I'm going to share over the next few slides is an Instagram post from Amanda of This Adoptee Life. And you can follow her on Instagram if you want to hear more from her and her experience as someone who is adopted. She writes, hoping to adopt, please read. What is the reason you are thinking you want to adopt? If it's to give a child in need of a family a loving home, be aware that international adoption is ridden with corruption as well as unethical and illegal ways to make children adoptable. If you are thinking about infant adoption, please be aware that many expectant mothers are coerced by family, by adoption agencies, and by society to go the route of adoption. Many women simply lack a bit of support, and they would be able to keep their baby, which is where the baby belongs, with the mother. Look into family preservation. Are you thinking of helping a child who's currently in the foster system? If so, there are options such as legal guardianship that I would suggest you look into, where the legal ties are not cut to the child's family. Once the child is old enough to decide if they want to join your family by adoption, then you can revisit the idea of adopting. But please make sure you're not going for a permanent solution to a temporary problem, which is sometimes the case with adoption. This is not even touching on the trauma for the child who loses their mother. Age and reason is irrelevant in terms of effects on the child. So, if in the end you do decide to adopt, make sure you have read up on early childhood trauma, that you know what coming out of the fog as an adoptee is. Make sure that you are truly able to put yourself aside and hold space for the adoptee child, as he or she may one day question adoption as a concept and practice, as well as your part in it. As Amanda brings up, there are ethical concerns with international adoption, adoption within our country, foster to adopt, and so forth. And her Instagram account, as well as her website, her blog, are really great places to learn more about those. While I wouldn't necessarily use information like this to discourage a patient from pursuing adoption or building their family a different way, it is really helpful as a genetic counselor to understand how complicated things can be for a child who is going through foster care or who is being adopted, and to understand the lasting impacts. And that when I'm talking with patients who are exploring in their mind, well, we're thinking about IVF, but we're also open to adoption, that I'm better equipped to discuss some of the challenges that can come along with adoption and the trauma that can come along with adoption, just like I can do so with IVF or with other options for patients who are at risk of having an affected child. Okay, moving on to possibility 4A, which is to significantly reduce the risk for disease in offspring using assisted reproductive technology. And there were two different options for 4. One was 4A, gamete donors or embryo donation, and 4B, utilizing PGT-M. So let's talk about gamete donors and embryo donation. With donor eggs or donor oocytes, there are a few different options, and you'll see the same is true for donor sperm and donor embryos. Egg donors can provide fresh or frozen eggs. So what that means is that a couple or a patient could select an egg donor that they're interested in, and that donor could go through a cycle, and the eggs could be fertilized with the patient's sperm or with the sperm donor of choice immediately. That would be a fresh donor. A frozen donor would be an egg donor who donated eggs, and the eggs were frozen, and a couple selects from, or a patient selects from, a list of a bunch of different egg donors with frozen eggs that are ready to go to be thawed and fertilized when the patient would like to proceed with treatment. Donor eggs can be anonymous, non-anonymous, or known. So anonymous would mean the idea is that the recipient and the future offspring would never know who the donor is. Now, this isn't really a possibility anymore with how cheap and readily available testing like 23andMe and Ancestry are, and the fact that pretty much anyone can use DNA testing to find, if not their egg or sperm donor, an egg or sperm donor's relative, and to narrow it down from there. But anonymous generally means that the person utilizing that donor gamete is not going to get any information that would personally identify the donor at any time from the bank or from the place that they're purchasing that gamete from. There are a lot of ethical concerns about anonymous donation and how it impacts people who are donor conceived, and I'll talk a bit about that in a few slides. Non-anonymous donors, this typically means that the donors have consented that they are non-anonymous, or that at some point in time, the recipient or offspring from the donation will be able to request their contact information. A known donor, on the other hand, that would be, if your family or friend is able to donate eggs on your behalf. Donor eggs can be purchased from donor egg banks. They can be purchased from donor egg agencies. Many fertility clinics run their own donor egg bank, or they can be donated, as I previously mentioned. Donor egg is really expensive. The cost of a donor egg IVF cycle is typically about $30,000 to $40,000, so it is not an inexpensive treatment. Donor sperm, similarly, they can be anonymous, non-anonymous, or known, same as what I mentioned with the egg donors. They are typically purchased through sperm banks or donated by friends, family members, or acquaintances. The cost for one vial of sperm, if you are purchasing it, is typically $900 to $1,500. And one vial of sperm could get you through one at-home insemination, one IUI, or a couple of IVF cycles. Next, let's talk about donor embryo. Donor embryos can be purchased through clinics. They can be purchased through donor embryo agencies or donated at no charge. Legally, the donation of an embryo is considered a transfer of property, not a legal adoption. And embryo adoptions can be closed, semi-open, or open, depending on what the donor and recipient desire. The cost of a frozen embryo transfer is typically about $3,000 to $6,000. So as you can see, it is much less expensive to utilize a donor embryo as opposed to selecting an egg donor and going through a whole egg retrieval with that egg donor and transfer of that embryo. Regardless of whether we're thinking about egg, sperm, or embryos, there are requirements set forth or guidelines set forth by the American Society of Reproductive Medicine that any anonymous or non-anonymous gamete or embryo should meet in order to be considered. That is one of the documents that I included in the zip file of resources for you all if you'd like to review it. Ethical concerns regarding donor gametes and donor embryos are aplenty. The biggest concern probably is the concern about psychological effects on children resulting from donor conception. Currently, ASRM strongly encourages that donor-conceived children are told their origin story and told it honestly and from a young age. However, 15, 20 years ago, that was not the case. And many donor-conceived people did not realize they were donor-conceived until it came up by accident, maybe when they discovered that their blood type didn't align with their presumed parents, or through doing 23andMe or Ancestry. From reading plenty of stories of donor-conceived people, it is clear to me that for many donor-conceived people, finding out that your presumed mother or father is not your bio mom or bio dad is extremely troubling and really impacts their life for a long time. I think it's really important as a genetic counselor to be aware that, yes, while donor gametes and donor embryos are part of fertility treatment, they affect the people that they create. Most donor-conceived people, almost all, agree that it is important and is their right to have their medical background, their ancestry, and to know genetic relatives if they desire to. Another possible ethical concern is the consent and counseling of all donors and all recipients, and making sure that donors and recipients understand possible implications. There are often concerns about biologic siblings meeting each other unknowingly or accidental incestuous relations. And for that reason, ASRM recommends a cap of 25 births per donor within a population of 800,000. And then also there are concerns with compensation, the legality of compensating a donor. So let's think about how donor gametes or embryo donation could help Tyrese and Meredith. Because they are both carriers of a recessive disease, and Meredith has expressed concerns about her fertility, and we know she's 40 years old, her fertility is certainly starting to decline. She'll have a lower success rate with IVF compared to somebody who's 30, for instance. An option they could consider is donor egg. If they use donor egg, they can choose a donor who's been screened and who's screened negative for SMA, and that alone will significantly reduce the risk for SMA. And then they can also use a donor who is in a younger age group and therefore is going to have a lower risk for chromosome imbalances, and it's going to be more likely that they would get embryos that are chromosomally normal and result in a healthy ongoing pregnancy. Alternatively, of course, they could use donor sperm. Donor sperm is much cheaper than donor egg, and if they use donor sperm, if they use donor sperm that's been screened for SMA and is negative, that would also reduce the risk for spinal muscular atrophy in offspring significantly. However, it won't help with the issue of Meredith's egg quality given her age of 40. And then finally, donor embryo could also be a choice. Now, many couples are not open to using donor egg, donor sperm, or donor embryo because they really want that biologic connection to their offspring. To be honest, most couples like Meredith and Tyrese who present to a fertility clinic with a history of a single gene disease that's affected their children or maybe their family significantly, and they're already familiar with PGT-M, most of the time those couples are not interested in utilizing egg or sperm donor, but depending on Meredith and Tyrese's fertility evaluation and what their reproductive endocrinologist sees, it may become more strongly recommended that they go the route of a egg or sperm donor. All right, and now on to the final option, which is preimplantation genetic testing. Preimplantation genetic testing is the analysis of the genetic composition of an embryo produced by IVF prior to implanting that embryo into the uterus. So PGT comes in many different forms, and it's continually evolving, which is one of my favorite reasons why I love working in the space of assisted reproductive technology. There's PGT-A, that's testing for aneuploidy or chromosome imbalances. PGT-M, we're looking for monogenic diseases, single gene diseases in these embryo samples. PGT-SR, structural rearrangements. That's the type that's utilized by gamete sources who have an inversion or a translocation. PGT-P, a controversial form of PGT, looking for polygenic diseases using polygenic risk scores. And then finally, the newest shiny PGT, that's PGT whole genome sequencing. And I'll talk about each of these in a little bit more detail, but it's important to know in order to perform any of these tests, the embryo needs to be grown out to a blastocyst stage, day 5, day 6, maybe even day 7. A biopsy, a small sample, usually between about 5 to 10 cells, is removed from the trophectoderm, the outer part of that blastocyst embryo, and utilized to get the DNA to perform any of these forms of PGT. So let's talk more about the different forms. Let's start off our conversation regarding PGT with PGT-M, or the preimplantation testing for monogenic diseases. This test was previously called PGD, or Preimplantation Genetic Diagnosis, and it is a technology that's used to test an embryo biopsy for a single gene disease. It is essential that the disease-causing mutation is known. If the cause of a disease is not known, PGT-M cannot be offered. Direct mutation analysis, like what would be utilized with CVS or amniocentesis when you go looking for the parental pathogenic mutation, is not sufficient with PGT-M. You cannot rely on direct mutation analysis for PGT-M, and I'll get to that reason in a little bit. So in addition to direct mutation analysis, or sometimes just instead of, linkage is used. Linkage sometimes is referred to as DNA fingerprinting, and that is completed to improve the accuracy. If we relied on direct mutation analysis alone, with such a tiny sample like what we get from an embryo biopsy, the accuracy could be very poor in certain settings. And if a pregnancy is achieved using a PGT-M screened embryo, prenatal diagnosis is recommended to confirm that the pregnancy is not affected. Prenatal diagnosis does have a higher accuracy than PGT-M. I want to explain just briefly how linkage analysis works to help you better understand how complicated PGT-M is. PGT-M setup, or sometimes it's referred to as probe development, is custom designed for every single family who comes through a laboratory store for PGT-M. Even though most labs have tested embryos for SMA or cystic fibrosis hundreds of times, the linkage analysis is still custom every single time. And the way that linkage works is that the lab is going to analyze single nucleotide polymorphisms, or SNPs, that surround the variant of interest. And those are called linked markers. They're going to be evaluated. So depending on the disease and the mutation that a laboratory knows is in the egg source and or sperm source, they're going to locate SNPs that live on each side of that variant of interest. In order to offer PGT-M, a family must have enough unique linked markers surrounding the variant of interest. Many patients who go through PGT-M setup or probe development are shocked to learn how complicated it is. So, for example, in the case of Tyrese and Meredith, they've had a pregnancy and a child diagnosed with SMA. And they knew that it didn't require any setup in advance. It was simply a test that was ordered on their child, on their daughter Molly, based on her symptoms, and then a test that was done on amniocentesis and came back pretty quickly in just a week or so without any setup being required. So oftentimes they're really surprised to hear that in order to design the PGT-M probe, we need samples, or the lab needs samples from family members to complete the linkage analysis. The lab will utilize the samples from the family members to study different SNPs and determine which markers are inherited with the pathogenic variant and which are inherited with the unaffected copy of the gene. If I was the genetic counselor working at the PGT-M lab to help Tyrese and Meredith, I would likely ask for samples from Tyrese and Meredith and either Tyrese and Meredith's parents, or a sample from one of Tyrese and Meredith's affected pregnancies or affected children. Tyrese and Meredith shared with me that their parents aren't available, but they did have DNA banked from Molly. So I coordinate with the storage facility to have some of Molly's DNA sent over to us so that we can utilize that at the PGT-M laboratory. Next, the PGT-M lab is going to study some SNPs that surround the variant of interest. To make things a little easier to see, I'm just going to label the different alleles as different letters in lowercase and capital. Because we know Molly is affected with SMA and Tyrese is a carrier of SMA, any SNPs that Tyrese and Molly share that Meredith does not have must travel with Tyrese's SMA mutation. So here, if we take a look at the different SNPs that were identified in Molly and Tyrese, we can see that they share lowercase b, capital A, lowercase d, and e. So those SNPs travel along, they are the linked markers to the SMN1 deletion that Molly inherited from Tyrese. After analyzing the SNPs, we can now make a partial map here of what's going on. We see the shared or linked markers between Tyrese and Molly, and we also see the markers that travel on the other allele that Tyrese carries. And then we'll do the same thing with Meredith. Using a DNA sample from Meredith and the stored DNA sample from Molly, the lab can compare what SNPs both Meredith and Molly share that Tyrese does not have. And those would be the linked markers, the markers that travel on Meredith's copy of chromosome 5 that has the SMN1 deletion. That would be capital G, capital I, lowercase f, and lowercase j. And then the other SNPs are the SNPs that travel on Meredith's unaffected copy of the SMN1 gene. Now we can put together the puzzle almost completely, and we can see the linked markers that Meredith and Molly share. If DNA samples from Molly and Jarrett were not available because the family structure was different, or maybe because a couple is identified on expanded carrier screening before they start trying to build their family, samples from Tyrese's and Meredith's parents or parent, depending on the situation, could be used to complete linkage analysis. After I explain linkage analysis to patients, oftentimes they'll ask me, why can't it just be easy? Why can't we just do the same type of testing that we did on the amniocentesis sample from my previous pregnancies? And the reason is ADO, or allele dropout. So if we fast forward to the stage of PGT-M where the lab receives the embryo biopsies from the couple and starts testing those embryo samples, that's where we can run into a problem. The embryo biopsies are just a few cells, so that is a tiny amount of DNA. And that DNA has to be amplified, typically using PCR. With PCR, the DNA strands are separated. A primer is used to make many, many copies of each of the strands of DNA. This is repeated over and over and over. Now, what can happen when you start with such a small sample of DNA is that it's possible that just one copy of the gene is amplified, instead of amplifying both copies of the gene. Let's say, for example, that a couple is utilizing PGT-M for cystic fibrosis, and the lab receives an embryo. And for the sake of this example, we know what the embryo is. The embryo sample is affected. We'll say that the embryo sample has a delta F508 mutation and a 2143 del T mutation. Now, if only one copy of the gene of interest is amplified, and we were relying on direct mutation analysis alone, what could happen is only the delta F508 deletion is amplified, and we only see that. We don't see a second mutation, and we assume that the embryo sample just represents a carrier. This could lead to a total misrepresentation. We could assume that the embryo is just a carrier and unaffected, and it could be recommended for transfer if we only relied on direct mutation analysis. And that's why linkage analysis is used for PGT-M. That way we have, 8, 9, or 10 linked markers flanking that gene of interest that can confirm what alleles the embryo inherited and give us a much higher level of accuracy than direct analysis alone could, or targeted analysis alone could. Importantly, there are a lot of limitations with PGT-M. The biggest one to know is that we have to know the disease-causing mutation in order to utilize PGT-M. PGT-M is not a way to just go looking for something for the first time. The accuracy is less than 100%. Usually it's quoted around 98%, but it can depend on how successful linkage is. A very common misconception among a lot of patients, unfortunately, is that PGT-M can correct mutations. That's not the case. Unfortunately, PGT-M is only used to identify whether each embryo has inherited a mutation or mutations. Another problem is that all embryos could be affected. Even in the case of a recessive disease where we know only 25% of embryos statistically should be affected with both mutations, all the time I see odds shake out differently than what we would expect. If there are not enough linked markers, the accuracy could be reduced, or sometimes PGT-M is not possible. Depending on the family structure, if a parent has a de novo mutation, That can make linkage very difficult and PGT-M may not be available. Additionally, if a child has a de novo mutation, but a couple or a patient wishes to test for it, PGT-M may or may not be available. And even if it is available, it has limited utility because if a child does have a de novo mutation, the risk for that to occur again is probably very low. And then one more specific limitation that is specific to trinucleotide repeat diseases, for example, Fragile X syndrome, is that PGT-M cannot determine the number of repeats in an embryo sample. It can simply determine whether the embryo inherited the allele that is at risk for expansion or the allele that is not at risk for expansion. All right, here we have Meredith and Tyrese's combined PGT-M and PGT-A results report. And this is really what a standard PGT-M and PGT-A report will look like. So let's just go through what's going to be included on the report. You can typically see when the IVF cycle occurred, when the biopsies were received by the PGT laboratory to perform the testing, and when the results were released or the report date. And then you can see what the indication is. It's first final muscular atrophy, and what variant the egg and the sperm source carry. Next, let's look at each of the columns on the results table here. So first we have the embryo number. You can see that embryo samples were sent from 2, 3, 6, and 7. And it is typical to see them, like some missing embryos, like the fact that we're not accounting for embryo 1 or 4 or 5, because most of the time, the vast majority of patients who utilize IVF, not every single one of their eggs that are retrieved will fertilize. Not every fertilized embryo will make it to blastocyst stage for testing. So it is normal to lose a good number of embryos throughout the process. So these are the 4 that made it to the blastocyst stage so that they could be biopsied and sent off to the PGT laboratory. Next, we have the PGT-M result. So for a recessive disease, of course, we're expecting there's probably 3 main results. An embryo could be a carrier, an embryo could be a non-carrier and unaffected, or an embryo sample could be affected. And then there is always a small chance for inconclusive results with any PGT testing. Let's look through the PGT-A results. So now this is our pre-implantation genetic testing for aneuploidy. You can see that embryos 2 and 3 were both aneuploid. They both had some sort of deviation from the typical 46 human chromosomes we'd expect to see. PGT-A can tell you what that deviation is. So for embryo number 2, we're seeing a single copy of chromosome 14 instead of the typical pair. So that embryo, if this result is accurate, probably would not be viable based on that aneuploidy being a non-viable chromosome imbalance, despite the fact that that's the non-carrier result. Embryo number 3, you can see it has 2 aneuploidies. Some labs might call this a complex aneuploid. It's got an extra copy of chromosome 7 and 21. If this embryo were transferred, which it would probably not be recommended to transfer it based on the PGT-A results, this embryo would probably not implant or miscarry early on. Embryo number 6, that embryo, there's a little bit more to this one. It says low mosaic, trisomy 20. A mosaic result suggests that there is a mix of both some euploid cells and some aneuploid cells together. And over the past 5 years, there's been loads of evidence about mosaic embryos and loads of outcome data published on mosaic embryo transfers. And what most studies are concluding is that while mosaic embryos might not be quite as good as euploids in terms of an ongoing pregnancy and live birth rate, the risks are looking pretty low, and low mosaic embryos certainly can go on to result in a chromosomally normal pregnancy if the euploid cells take over and the abnormal cells with the trisomy 20 die off. So since this embryo is a carrier and it has a low mosaic PGT-A result, this embryo might be an embryo that could be considered by Tyrese and Meredith and the doctor. Finally, and lastly, we have embryo number 7. This embryo was reported to be affected with PGT-M, so affected with spinal muscular atrophy, but the PGT-A result was euploid. Now, since one of the main reasons this couple did PGT-M was to avoid transferring embryos that were impacted, they're probably not going to want to utilize that embryo. So this result report is actually a pretty common, it's a pretty likely outcome for couples, especially when the egg source is in their 40s who are utilizing PGT-M and PGT-A. Things just don't always shake out, especially on that first cycle, the way that we're hoping for. So this couple might have one embryo, that embryo MC6, that they might consider transferring depending on their doctor's thoughts. But even with a euploid embryo, live birth rates when you transfer a chromosomally normal euploid embryo are usually quoted somewhere between about a 45 to 65% chance. And the chance for a ongoing pregnancy or live birth with a mosaic might be closer to 40 to 50% chance. So it is definitely not a guarantee that they'll have that third child. Let's talk a little bit about preimplantation genetic testing for aneuploidy. It was previously referred to as PGS, or preimplantation genetic screening. PGT-A can determine whether each embryo sample is euploid, chromosomally normal with 46 chromosomes, or aneuploid, chromosomally abnormal. The specific errors typically are reported so you can see what the aneuploidy or aneuploidies are, and it also can determine sex chromosomes. Limitations of PGT-A: the accuracy is not perfect. Most laboratories quote around a 97-98% accuracy for chromosome imbalances. The sample that is being tested is a tiny sample of trophectoderm, so the result is the result of that sample. You cannot test the whole embryo because that would destroy the embryo. So because we're testing this one little sample, we can't rule out mosaicism. There's always a possibility that even if the majority or all of the cells in that sample were normal, that there could be some abnormal cells elsewhere in the embryo, perhaps in the cells that will grow to make up the fetus, or vice versa. And then finally, with PGT-A, you cannot detect small losses and gains. Typically, the threshold for PGT-A is about 10 megabases, or 10 million base pairs, and losses and gains smaller than that may not be observed. And because it is not making a karyotype or a picture of the chromosomes, you cannot see any structural changes utilizing PGT-A. Now, PGT-A is not without controversy. Depending on the provider or the clinic that you go to or speak to as a patient, you could hear very different opinions about PGT-A. One of the big questions about PGT-A is, does the biopsy required for PGT-A impact the quality or the chance for live birth? And that's an area that's still debated. Another big question is, how much does PGT-A really improve the chances for a healthy live-born baby? That's also debated. Well, over the past 3 or 4 years, mosaicism has been a very hot topic in the world of PGT-A. It's estimated that depending on the lab that does the testing, 5 to 20% of embryo samples are found to be mosaic. The problem is we've only been able to detect mosaicism in embryo samples for the past 6 or 7 years. And we are still just beginning to understand the possible outcomes when you transfer mosaic embryos. Though what we're seeing is that embryos that are low mosaic or have a smaller portion of abnormal cells compared to normal cells do have a pretty good chance of resulting in ongoing pregnancies, and that the risk for an adverse outcome is probably pretty low. But there's still a lot to learn. For that reason, many clinics are not willing to transfer mosaic embryos, and some clinics don't even disclose mosaic results to their patients. I think this graph is really helpful to look at, and you might be surprised to see what the aneuploidy rates are related to maternal age. This is data from iGenomics. You can see that for women under the age of 35, about 41% of the embryos that are tested come back chromosomally abnormal. By the age of 38 to 40, about 62% of the embryo samples come back abnormal. And by age 43 to 44 for the egg source, only 24% of the embryo samples are returned as euploid. During my time at iGenomics, I counseled thousands of couples on their PGT-A results, and a lot of patients were shocked about this. So it's really important that patients have pre-test counseling, that they're aware of these aneuploidy rates prior to undergoing PGT-A. All right, now that we've covered PGT-M and PGT-A in a good level of detail with that case example, I'm going to spend a slide each on some of the less frequently used forms of preimplantation genetic testing and some of the new up-and-coming PGT technologies. Let's begin with PGT-SR, or preimplantation genetic testing for structural rearrangements. This type of PGT has been around for a long time now, and it is simply used for individuals' gamete sources who carry a balanced chromosome rearrangement, like a reciprocal translocation or an inversion. So individuals who carry a translocation or inversion You can't tell looking at them. They're healthy typically or don't have any findings related to being a balanced carrier. However, we know they have an increased chance to have pregnancies, embryos, babies who are impacted with an unbalanced form of that translocation or inversion. So PGT-SR is recommended if we know that a gamete source has one of these rearrangements. And it's pretty similar to PGT-A. It can also detect aneuploidies in any of the other chromosomes that are not involved with the rearrangement, but the main goal of it is just to zoom in a little closer on the chromosomes that are involved in the rearrangement and to have this better resolution to detect smaller losses or gains than standard PGT-A. Some of the limitations are that, it can't zoom in perfectly. So sometimes there's an imbalance, rearrangement that's too small to be detected even with PGT-SR. So you can't necessarily utilize it for any rearrangement. And most labs are going to need to look at the karyotype of the impacted gamete source to confirm that their PGT-SR can indeed detect the imbalances. And then lastly, because PGT is a quantitative test, it's not making a karyotype or a picture of the chromosomes. It's measuring how much material is present from each chromosome. Unfortunately, PGT-SR cannot differentiate between embryo samples that are balanced carriers and those with typical chromosomes. So some parents or patients really hope to only transfer embryos who have typical chromosomes and not inherit the balanced translocation, for example, but PGT-SR cannot see that. It can't differentiate between the two. Next, let's talk about PGT-P, or preimplantation genetic testing for polygenic diseases. PGT-P uses polygenic risk scores, or PRSs, to estimate an embryo's risk for some common and complex or multifactorial diseases. I'm talking conditions like diabetes, coronary artery disease, schizophrenia, and you can see a few other conditions listed in this sample report that I pulled. So these scores, these PRSs, are built from genome-wide SNP data and large population studies, but it's important to know that the scores are really dependent on the quality of these data sets. It's also important to know that for any multifactorial disease and for PRSs, all that can be provided is a relative risk, not a concrete diagnosis. So no one can say an embryo will or will not develop a specific condition, just that based on their data, the statistical risk might be slightly lower or higher than the general population or than other embryos. Now, if you look at the sample report, which I pulled from LifeView, their embryo health score, you'll see exactly how these results are presented. So they're presented as percentiles or relative risks across embryos, rather than these predictions. And you can see that they compare them to average or general population risk. Now, in reality, this is kind of one of the criticisms of PGT-P. The difference between embryos created from the same egg source and sperm source is likely fairly small. This is really where the controversy comes in. The predictive power of PGT-P is still thought to be fairly modest. We know there are issues with ancestry bias and, who's actually, what ancestry of individuals are in these data sets that we use. Could PGT-P be less valuable for individuals with certain backgrounds compared to mixed European ancestry individuals who the data sets are typically, who's typically contained in the data sets? So this along with the fact that polygenic diseases and multifactorial diseases are also somewhat significantly impacted by lifestyle and environment are some of the criticisms of PGT-P. Now, as I mentioned on the last slide, there are criticisms of PGT-P. It's definitely considered controversial depending on who you speak with. And at the end of last year, at the end of 2025, ASRM came out with a ethics committee guideline on PGT-P. And I just wanted to summarize this really quick. It is a good read and a short read if you're interested in it. But essentially, the main points are that the predictive value is limited. Polygenic risk scores only capture a small fraction of disease risk. So it's inherently an incomplete assessment. Like I said, the risk for these conditions is often heavily influenced by the environment and medical care. So a lot of those things you just cannot predict at the embryo stage. Third, there's no evidence that using PGT-P is going to improve clinical outcomes. So we don't yet have data showing that this is going to lead to healthier children. And PGT-P is not improving the chances of an embryo implanting or anything like that. So it's adding another test without evidence that it's going to improve clinical outcomes. Ultimately, in addition to these ethical concerns like bias and equity, our patients really consented in understanding the limitations of this testing. ASRM determined that this PGT-P at this time is not recommended for clinical use. It should be research based only at this point in time. And finally, let's move on to the newest and shiniest PGT. This is pre-implantation genetic testing, whole genome sequencing. At a high level, what this involves is sequencing the embryo biopsy's genome, just relying on that same trophectoderm biopsy that you would use for PGT-A. But instead of targeted testing, we would be looking much more broadly across the genome. One of the big potential advantages and one of the biggest appeals to me is that it's comprehensive. So in theory, PGT-WGS could combine what we currently do with PGT-A, PGT-M, PGT-SR into a single platform and even go beyond that, really. It definitely raises the possibility of identifying de novo variants that wouldn't be picked up in our targeted PGT-M approach that's currently used with linkage analysis. But at this point in time, it's still really new. There are definitely some limitations and challenges, and I can tell you it is not frequently utilized at this point in time. I would say it's still very much an investigational or research-based approach. I don't see patients coming through using this often at all. But limitations, important to know, because you're working with such a small amount of DNA, there are risks that with that low DNA input, there could be allele dropout or amplification error and something could be missed. And then there's also the interpretation burden. Just like we think of how long it took scientists and researchers to be able to interpret WGS for a child with clinical indications, you're obviously going to run into problems, the same types of problems with interpreting WGS for embryo biopsy. And then finally, same as I mentioned with PGT-P, because this is so new, certainly there is not any data yet to show that this improves clinical utility, that this improves the chances of pregnancy or live birth, or that this improves outcomes for children or makes there a highly likelihood to have healthy children. So this is a really exciting type of PGT that I'm really excited to see how it evolves and what the uptake is once it's more widely available, or to be involved in having some embryos tested with PGT-WGS. Definitely something to kind of keep on your radar, as I know there will be more coming out each year with this form of PGT. I wanted to include a couple of resources for any of you who are interested in learning more about reproductive medicine or specializing as an ART genetic counselor. These are some really nice free websites and resources to check out if you want to keep learning more. And then finally, here are my references. Thank you all so much for listening, and I'm looking forward to seeing you at discussion.